Hello, everyone. Today we'll discuss prioritization in pain management. Let's begin with the assessment domain and how to approach pain systematically. When caring for any patient in pain, always begin with a direct and complete assessment. Ask the patient to describe where the pain is located, what it feels like, how severe it is, and what makes it better or worse. Never assume you already know what they feel. Two people with the same diagnosis can experience completely different types of pain. If a patient reports that nurses haven't been responding to pain medication, your first step isn't to assign blame. It's to assess. Look at both how the staff have been responding and how the patient has been communicating their pain. When a patient is cognitively impaired or unable to communicate clearly, look for nonverbal signs such as grimacing, rocking, or guarding. Ask family members how this person normally behaves when comfortable versus when in pain, so you can recognize subtle changes. If pain worsens after surgery despite medication, do a focused reassessment before giving another dose or calling the provider. Check for complications like bleeding, infection, or obstruction before assuming the medication isn't strong enough. Now for red flags in pain evaluation that you should always be aware of. Certain findings require immediate attention. A rigid abdomen with rising vital signs can signal peritonitis or internal bleeding. Confusion, restlessness, or anxiety that seems out of proportion to the situation might mean hypoxia, worsening perfusion, or poor pain control. And if a patient ever says something like, "I think I'm going to end it," treat that as a suicidal emergency. Safety becomes the first priority. Now let's talk about the sociocultural and psychological aspects of pain. Pain has emotional and cultural layers. Ask open questions such as, "What do you believe about pain medicine and addiction?" to uncover any misconceptions. If a patient's fears or cultural beliefs are affecting their willingness to take medication, let them express those emotions before you begin teaching. Listening first builds trust and opens the door for honest education later. Now we'll move into the intervention domain and discuss what to do once pain is assessed. Starting with opioid management and safe use of narcotic medications. Extended opioid therapy is most appropriate for patients with progressive cancer pain because their pain tends to worsen as the disease advances. Watch for respiratory depression. The patients most at risk are older adults, those who are opiate naive, and anyone with a chronic lung disease, such as COPD or cystic fibrosis. If a post-operative patient using a PCA pump reports poor relief, reassess before adjusting the dose. Sometimes the line is kinked, sometimes anxiety plays a role, and sometimes the pain pattern has changed. For patients with constant pain, schedule medications around the clock instead of waiting for pain to return. Consistent dosing keeps the medication level steady and prevents unnecessary suffering. Next, let's review non-opioid and adjuvant therapies for pain management. For diabetic neuropathy, the preferred first-line medication is gabapentin. Use corticosteroids for pain caused by inflammation. NSAIDs work well for musculoskeletal pain, but do little for nerve pain. Always give them with food to avoid stomach irritation. Lorazepam may help ease anxiety that worsens pain, but should never be used as the primary analgesic. It's an adjuvant, not a replacement. Now for the key titration principles when adjusting pain medications. When titrating pain medication, the goal is to find the smallest effective dose that controls the pain with the fewest side effects. Increase gradually when pain persists and decrease when pain improves. The goal is steady comfort and safety, not oversedation. Let's talk about managing adverse effects that can occur with pain medications. If a patient's respiratory rate drops to 10 breaths per minute after receiving an opioid, your first step is to assess. Check responsiveness, airway, and breathing. Only after you've evaluated the patient should you prepare to administer naloxone. Oxygen by nasal cannula can be delegated to an LPN after it's ordered, but the RN maintains responsibility for monitoring. Unlicensed assistive personnel can report low respirations, but may not interpret what those findings mean or decide when to intervene. Now we'll look at non-pharmacologic measures and how to use them safely. Always document non-drug comfort measures. They matter. Applying heat or cold packs can be delegated to an LPN or a trained UAP, but teaching or evaluating their effectiveness belongs to the RN. Meditation, relaxation, or therapeutic touch. require nursing judgment and a willing patient. If electrical stimulation is prescribed, such as a TENS unit, that's usually handled by physical therapy. Now we'll move to the teaching domain and review what patients and families need to understand about pain management. Education is central to effective pain control. Teach patients that the risk of addiction is minimal when pain medications are used properly under medical supervision. Validate fears before correcting them. Show that you understand their concern first. Include all 5 dimensions of pain in your teaching: cognitive, behavioral, sensory, affective, and sociocultural. For chronic or cancer pain, emphasize consistent dosing and awareness of side effects. When a family member asks for more medication, respond by saying you'll check on the patient and reassess their pain. That maintains professionalism and patient safety. Now let's review withdrawal and tapering so you can recognize early signs. The first sign of opioid withdrawal is sweating, or diaphoresis, which usually begins 6 to 12 hours after the last opioid dose. Late signs, such as fever, nausea, and abdominal cramps, appear after 48 to 72 hours. Knowing this timeline helps you manage withdrawal safely and compassionately. Next, let's talk about ethical and cultural sensitivity in pain management. Giving a placebo is unethical and damages trust. If you're ever asked to give one, talk with your charge nurse right away and review hospital policy. Maintain empathy and honesty in every pain conversation, no matter how difficult. Now let's review team responsibilities for delegation and safe scope of practice. Unlicensed assistive personnel can assist patients with hygiene and can help prepare a sitz bath under supervision. They may apply heat or cold only if they've been trained to do so safely. They can measure urine output, collect specimens, and report observations, but they do not evaluate or interpret results. They never insert catheters, give medications, or decide when to act on abnormal findings. LPNs or LVNs can also assist with hygiene and sitz bath care. They can apply heat or cold as part of the established nursing plan. They can perform neurologic and circulatory checks when those steps are outlined by the RN. They may give oxygen through nasal cannula when it's ordered. They can insert simple, uncomplicated Foley catheters, but not complex ones. LPNs cannot teach, cannot evaluate pain relief, and cannot make independent decisions about titration or contacting a provider. The RN supervises all of these activities. The RN teaches and assesses the use of heat and cold therapy, evaluates pain relief after any intervention, and interprets neurologic or circulatory findings. The RN is solely responsible for teaching new devices such as PCA pumps, giving Narcan, titrating a PCA, and contacting the provider when needed. The pattern is simple. The RN teaches, assesses, and evaluates. The LPN carries out stable, predictable tasks within the plan, and the UAP supports basic care and reports findings. Now, let's go over the prioritization and safety domain and how to decide who needs care first. Use the ABCs and safety as your guide. Always accept the patient's report of pain as true. Address airway and breathing problems first, especially if opioids may be causing sedation. Watch circulation closely in postoperative patients for bleeding or abdominal rigidity, and never overlook patient safety. Monitor for withdrawal, stigma, or suicidal thoughts. If you have several patients, the one whose chest tube is about to be removed should be assessed first because of the risk for dislodgement or pneumothorax. If a postoperative patient reports worsening pain, assess thoroughly before calling the provider. If a patient with chronic pain expresses suicidal thoughts, place safety precautions immediately. Life comes before comfort. If a diabetic patient refuses insulin while showing signs of hyperglycemia, notify the provider immediately because diabetic ketoacidosis can be fatal. And if a patient's PCA pump seems ineffective, reassess the location and quality of the pain before requesting a change in medication. Now let's talk about assignment principles and how to match the right nurse to the right patient. Experienced RNs should take care of trauma patients, postoperative patients with chest tubes, patients with severe headaches of unknown cause, and anyone with chest pain and a cardiac history. These are unstable patients who require frequent assessments. LPNs or LVNs can manage stable, predictable cases such as postoperative patients with casts or amputations, people with arthritis who need scheduled medication, and patients with diabetic neuropathy. They should not be assigned to perform preoperative teaching, handle emotional crises, or care for new trauma cases. New graduate RNs should be assigned patients with predictable needs, such as routine dressing changes, mild IV site discomfort, or kidney stones needing PRN pain medication. Avoid assigning complex or emotionally heavy cases until the nurse gains more experience. Now let's review SBAR communication and how to present information clearly to the provider. Clear communication saves lives. SBAR stands for Situation, Background, Assessment, and Recommendation. Start by identifying yourself and your patient and stating the current situation. Next, provide the background. Include diagnosis, recent surgeries, and medications. Then share your assessment findings and what you think is happening. Finally, make a recommendation for what needs to be done next, such as requesting orders or further evaluation. SBAR keeps conversations concise and professional while showing that you've already thought through the problem. Now we'll cover behavioral and ethical considerations to remember in pain management. If patients complain that their pain is being ignored, address the issue directly and respectfully with your team. Avoid bias. Whether a patient is stoic or expressive, each deserves equal attention. Follow your ethical standards and use the chain of command if you feel unsure. And remember, suicidal statements require immediate action and provider notification. Now let's go over medication and safety pearls. These are the drug facts you must know cold. Gabapentin is used for neuropathic pain. Teach patients that it can cause dizziness and must be tapered gradually. Morphine treats acute and cancer pain. Monitor respiratory rate and sedation, and schedule it around the clock when pain is constant. NSAIDs are used for musculoskeletal pain. Always give them with food and remind patients that they don't help nerve pain. Corticosteroids relieve inflammatory pain. Monitor for high blood sugar and infection risk. Lorazepam is an anxiety adjunct. It should never be used as a primary analgesic. Narcan, or naloxone, reverses opioid overdose. Monitor closely because its effect wears off quickly and resedation can occur. Insulin and IV fluids are essential for diabetic ketoacidosis. Refusal of these treatments may signal suicidal intent and must be reported immediately. Now let's review the top 10 never miss points for pain management. Number 1, always assess before you medicate or escalate care. Number 2, believe and validate every patient's report of pain. Number 3, gabapentin is the first-line medication for diabetic neuropathy. Number 4, long-term opioid therapy is reserved for cancer pain. Number 5, a respiratory rate of 10 or less requires immediate assessment and possibly naloxone. Number 6, sweating or diaphoresis is the earliest sign of opioid withdrawal. Number 7, giving a placebo is unethical. Always consult your charge nurse. Number 8, suicidal thoughts in a chronic pain patient are the highest priority. Number 9, after chest tube removal, reassess right away to ensure stability. And number 10, if a diabetic patient refuses insulin during severe hyperglycemia, treat it as both a medical and psychiatric emergency. In summary, pain management is about more than medication. It's about safety, trust, and compassion. Assess without bias, intervene thoughtfully, delegate appropriately, and advocate for your patient every time. Believe the patient, act with intention, and think before you medicate. That is the heart of professional nursing care. If this helped you master another concept, hit like, share it with your classmates, and subscribe for the next Dr. Atkinson lesson.